Ladies and gentlemen, good afternoon and welcome to our webinar series presented today by Professor Frossard, gastroenterologist, and Dr. Eschenberger, anesthetist, both from the University Hospital of Geneva. Before giving, my name is Ingrid Crevoiserat and I'm the Administrative Director at Swiss Medical Gate. Before giving the floor to Professor Frossard, let me please shortly present you Swiss Medical Gate with a few slides. Meanwhile, the interpreter will do the translation into Russian. Oh, why doesn't, sorry. I'm sorry. Swiss Medical Gate act the same way as a concierge in a hotel. Ask us and we will do the rest. We work for you, we provide you information, advice, and our extensive network gives us privileged access to Swiss professors, doctors, hospitals, private clinics, and much more. Our multilingual team will combine you an à la carte medical needs and make you as comfortable as possible. Why does people choose Swiss Medical Gate? Some of the reasons are listed below. Due to our 15 years, first of all, because we offer an all-inclusive service with a single point of contact, which makes it easier for everyone. And due to our 15 years of experience in the medical fields, we can propose you the best specialist and well-renowned establishment. We can help the patient making his decision. We support with the administrative procedure, such as visa, laissez-passer, or even finance. We assist the patient throughout his medical stay. And for the comfort of the patient, we follow him up after returning home. If necessary, interpreter accompaniment for him or his family will be organized. Above all, our multilingual team is here to ease the patient's stay. Let's talk about coordination. Our team is an international medical coordination, and they will take care of the following. They schedule the patient's appointment. They provide direct access to the best practitioner because patient's health is what's important to us. They organize, if necessary, a pre-travel online consultation. The secure transfer of the medical data. They coordinate pre- and post-operative medical exam and consultation. They also coordinate surgery, medical treatment, and appointment. They be present at the check-in and check-out in the clinic. They organize post-operative care assistance in Switzerland if requested. They'll be checking all the medical invoice received. And finally, they will be handling the final medical file to the patient. In a word, assisting the patient wherever it is necessary. Our goal is to satisfy you, but above all, we are listening to the patient needs, to the patient's request, and make him our main priority as you do for your own clients. This is the main reason of our slogan, patient first. Now, coming back to the webinar, please feel free to ask your question anytime during or after the presentation of the doctors. And for the smooth running of it, we just kindly ask you to switch off your microphone and your camera. I now hand it to Professor Frossard, and I wish you all a very pleasant webinar.
Okay, good morning, everybody. Thank you very much for the kind introduction, Ingrid and Marina. I'm sure you are here. I didn't see you so far, but I'm sure you're here. Thank you anyway for the kind introduction, and I'm be glad to share my slide. I am today with Dr. Eschenberger. He's the anesthesiologist in charge of our patient, digestive patient mainly, and I know him very well since a long time ago. So we work very close together, and it's a pleasure to work with Alain-Stephane because we need to trust the company we have, in fact, when we deal with patients. So I'm trying to share my screen today. Yes, here we go. So this is, in fact, Are you watching my screen? Is it okay for everybody?
It's all fine, Doctor.
Okay,
Professor,
perfect,
sorry,
sounds great.
fine. Thank you.
So this is one of the main picture of our hospital. This is Geneva University Hospital. It's not a big hospital in Switzerland anyway, but it is one of the major one for internal medicine and digestive disease. This is a new building, so that's the reason why I'm just showing it. What I am doing in Geneva, I'm the head of the Service of Gastroenterology and Hepatology. This is just a short list of what we are doing every year. We are performing about 9,000 endoscopic procedures. Most of them are made with the work of the anesthesiologist, and Alain-Stephane is just close to me. We are running also 6,000 outpatient consultations, might be from Switzerland or maybe from other countries, such Russia, for example. And we are the main leader for liver transplantation. We have made about 61 liver transplant last year. So it is a continuous progress, and we are the main center for pediatric transplantation as well. The Service of Gastroenterology and Hepatology is counting about 56 medical nurse and administrative staff. We are conducting research about pancreatic disease, and I'm just conducting myself 2 research labs in the Geneva University Hospital. So we can do everything, of course, but as you know, we cannot do anything because we need sometimes money to invest specific fields in the medicine. And we have targeted, in fact, several diseases in Geneva. We are just dedicated to liver disease, such as NASH, NAFLD, alcohol-related disease. I'm mainly concerned by pancreatic disease, mainly pancreatitis, chronic or acute, and pancreatic cancer, who is emerging right now. We are also doing interventional endoscopy, mainly polypectomy, and maybe mucosectomy, endoscopic submucosal dissection, as well as any catheterism of the biliary tract and the pancreatic tract, and it will be my topic today. So one of the major issue we have in Switzerland as well as in France, this is to deal with pancreatic cancer, and this is really a real challenge because the incidence is increasing everywhere in Europe, and I will just show you some slides reflecting what I'm saying right now. This is just a few words of epidemiology about this cancer. As you can see, this is the 4th cause of death in the US. We have counted about 3,000 cases a year, which is very huge, in fact. And the problem is everybody is dead by the end of the year. So it is really a deathful, in fact, disease. This is a 9th cause of cancer in the US. And as you can see here, we have an increased incidence over the years, 3 and 9 now in 98, which is very fast growing, and we have some data indicating who is responsible for this. Mean age 60 years old about, and as you can see, this is a big issue. In fact, almost all cases are non-resectable by surgery because it's too late. The people are coming very late seeing a doctor, and the question is, when we see the patient, we cannot offer just chemo radiotherapy because the disease has invaded vessels, major vessels, and gut, and it's not operable at all. This is, in fact, the translation. 1 year survival, when you do nothing, it's about 8%, 5 years survival, even if you do surgery, sometimes it's just 3%. So we need definitely to make improvements to diagnose the most quicker, I would say, the disease, and offer the skillful, I would say, surgery by our surgeon. This is a very interesting but dramatic, in fact, slide showing the increasing incidence of pancreatic cancer in France since 1985. And you can see it is rising very abruptly in men as well as in women. And one of the responsible for this is smoking. Tobacco is mainly responsible for 40–45% of the case of pancreatic cancer. So we really need to discourage everybody smoking, to quit smoking as soon as possible, to try to reverse this curve, which is very dramatic. It's not only in France, as you can see here, all the countries in Europe are in fact concerned by this increase. maybe not really Russia, but if you can see here, Denmark, Estonia, Finland, Iceland, Ireland, everybody is concerned, and we need definitely to work on this. We have, in fact, a very interesting and very, I would say, frightened data about the cancer of the pancreas. As you can see, this study, it was published in 2017. We are expecting more deaths from pancreatic cancer than the breast cancer. And this is just awful to say it, because you know that the breast cancer is very frequent among women in Switzerland, I don't know, in your country. So we need definitely to work very fast and to prevent this increase to become even bigger in the coming future, sorry. Tobacco, I told you that it will be a major contributor to pancreatic cancer. As you can see in this small slide here, the active smokers compared to non-smoker have an increased risk of pancreatic cancer about threefold when you compare the reference, so non-smoking status, past smoker, recent or maybe old smoker. So we need definitely to I have some sound coming back to me. Yes, maybe if you can just get your microphone, just thank you very much. So we need to fight against smoking habit and try to convince every patient to quit as soon as possible. In my consultation as outpatient, I'm always, in fact, emphasizing the fact that she should quit as soon as the day after they saw me, because I know that smoking contributes a large amount of pancreatic cancer. Obesity is also a risk factor for pancreatic cancer, as you can see, compared to different cancer. Prostate compared to pancreas, the relative risk is very high, 2.6, and for the liver, 4.5. So we need also to fight against obesity, and we have here in Geneva a large program of bariatric surgery to avoid this kind of issue. Diabetes, also a busy slide, I'm sorry, but this is just to show you that the cancer of the pancreas is very frequent among patients with diabetes compared to this slide. We need also to fight against diabetes. We don't know exactly why is the reason you have a more frequent incidence of pancreatic cancer in patients with diabetes. Might be that insulin is a growth factor and may contribute to the cellular ingrowth. It's a feeling not really proven so far. So when you have a patient with a pancreatic nodules, because you know that every patient with a pancreatic cancer will present on the hospital with pancreatic nodules, we need to make a differential diagnosis, and the first diagnosis will be cancer for sure. 80% of the nodule of the pancreas will be represented by cancer. Then you can imagine other cancer, but very, it's rare, a neuroendocrine tumor, for example. We have cystic neoplasia, we have acinar cell neoplasia, very rare case of pancreatic cancer, but it's not so severe. And we can think about lymphoma, we can think about inflammatory mass. What I'm saying here, we need to assess the diagnosis of the nodule. So we need to put a needle inside and to remove cells that we can just look at under the microscope. This is the reason why we need to puncture every mass, every nodule in the pancreas to assess the formal diagnosis. The idea is to avoid to send the wrong patient to the right surgeon and to send the right patient to the right surgeon. We have many cases of patients with inflammatory mass which are not relevant for surgery. We can just treat the patient by steroids, for example, and this is just to avoid surgery. So we need definitely to assess this kind of nodule. So when you think about a patient age 60, male, tobacco use and chronic pancreatitis, you almost have the diagnosis of pancreatic cancer. But it's not enough. You need definitely to make a puncture in the pancreas to assess the diagnosis. Once again, it's very important. So what we can do, we are using in Geneva the famous endoscopic ultrasound. This is an echograph at the tip of the scope. You just steer down the scope into the duodenum, and you can do images for the pancreas, the biliary tract, the liver. As you can see here, this is a transducer in this part of the duodenum. You can just very well visualize, in fact, the common bile duct, and you can see if it is empty or not. And here you can just see a stone into the common bile duct that is in connection with the liver and with the gallbladder. This is a very interesting technique because it's very effective. I would say that you don't miss the patient who has a nodule or a stone. We are very accurate, even more compared to MRI or sometimes to a CT scan, definitely. This is some chosen pictures of the spatial resolution of endoscopic ultrasound. So the transducer in the second part of the duodenum, you can see here the gallbladder, which is empty of stone, but you see the common bile duct. And here we have a small stone with a echo negative behind the stone. Here is another example of what we can see in the gallbladder. This is a patient with acute pancreatitis. He has CT, MRI, everything was normal, which we are just doing the EUS, endoscopic ultrasonography. And in this patient, we saw the cause of acute pancreatitis. It is just viscous bile into the gallbladder that should be removed by surgery, and so we can avoid any recurrence of acute pancreatitis. This is, in fact, the operating room we are using with the anesthesiologist. Alain-Stephane will be talking about anesthesia. This is just to show you some pictures. We are just steering down the tube into the duodenum, and I would say the most difficult part is to avoid bubbles and motility of the gut. And then you have just to find the papilla, which is in fact the last portion of the common bile duct and the pancreatic duct, and then you can cannulate, in fact, this small area. This is, in fact, the papilla. So this is really like Swiss clock. This is really tiny, small, I would say, organelle. You need to enter with a needle into the papilla to cannulate, in fact, the common bile duct and the pancreatic duct to remove stones or to remove parasites, or sometimes to put stent in place when the patient has a jaundice, for example, due to the compression of the common bile duct by the pancreatic cancer. And this is exactly what I'm just talking before. This is just the EUS, endoscopic ultrasonography. The transducer is within the stomach, and we are just searching for the nodule. This is, in fact, the pancreatic disease. We see here a mass of the pancreas, and when you are using the elastography, we are measuring the stiffness of the pancreas, and we compare the stiffness of the mass compared to the, I would say, healthy pancreas, and we can calculate, in fact, a ratio that indicates if this is suspicious or not. In this case, this is a clear-cut mass of the pancreas with the cancer. We do not need, in fact, to make a puncture. So far, we are doing it because we need more experiment, but just facing this color, this measure of stiffness of the pancreas, we can assess very precisely that the fact the patient has a big tumor. This is, in fact, a deeper insight into the pancreas. This is very blue, and this is a very, very large mass of the pancreas. This is adenocarcinoma, and the patient has to be punctured. We are just puncturing, in fact, this a nodule using a needle, 20 gauge or maybe sometime 90 gauge to remove cells, so we can have the rapid onset on the bed of the patient to have the diagnosis as soon as the patient will get out from the room. This is the second picture showing, in fact, here a large mass of the pancreas, and we can understand why the patient has a jaundice, because this is, in fact, the common bile duct, and the common bile duct is very dilated, should be 8 millimeter in size. This is about maybe 18, and with a mass obstructing the common bile duct. So we have the explanation. We puncture and we put a stent in place to keep the patient safe from cholangitis, inflammation of the bile. This is a second case of cystic neoplasia. This is a very well circumscribed lesion containing fluid. We are just entering a needle into this cystic lesion, remove cells and liquid, so we can analyze and give a formal diagnosis after a couple of hours to the patient. So we can sometimes avoid any surgery because this is a benign neoplastic cystic lesion. We do not need surgery, otherwise we send the patient to the surgeon. So when you have a patient with a compression of the biliary tract, we need to put a stent in place. This is the reason why we are doing cannulation of the papilla, as I just showed you before. We enter, in fact, the small papilla, we enter the common bile duct and the Wissung duct and put in place a stent so that the bile can just go to the right place at the right time. This is, in fact, once we have cannulated the papilla, this is the papilla, and we are entering, in fact, the papilla using a catheter into the common bile duct, and we are just trying to, in fact, introduce some more devices into the common bile duct. This is the common bile duct, the left portion of the liver. This is the right portion of the liver, and we're just removing sometimes some debris, sludge, or stones. We have to cut, in fact, the papilla to make possible the passage of the stone from the common bile duct into the duodenum. This is, in fact, the most tricky part because you can face either bleeding, sometimes perforation, or acute pancreatitis. So we have to tailor, in fact, the size of the papillectomy according to the size of the biliary tract disease. Sometimes it's not possible, and we're just using balloon to dilate, in fact, the tract, try to remove the stone if it is entrapped into the common bile duct. This is the stuff we are doing every day. So this is a sphincterotomy. We are using a snare and electric coagulation section that we have to tailor again the size of the papillotomy when we consider the size of the common bile duct to make possible the extraction of stones or whatever it is in the common bile duct. So my conclusion, it was fast, but it is important just to have maybe some discussion about it. We need to be concerned by the fact that cancer of the pancreas is a challenge in 2021, not 20. I just forgot the two. The problem is the late diagnosis of this disease, making the fact that we have difficulties in offering good treatment for the patient. We have a poor survival because the patient got often late to the admission and to the outpatient. And we need, in fact, to act maybe upstream, preventing obesity, smoking, tobacco, diabetes. I think it is my concern today. As soon as I told you, as soon as I have a patient who is smoking in front of me, I'm saying to him, you need to quit tomorrow. So maybe we can just go with Dr. Eschenberger, and then we can reply to some question if you have. Do you agree, Ingrid or Marina?
I totally agree. No,
okay.
So far I don't see any questions, so you can carry on with pleasure.
Okay. Je vais ouvrir juste la présentation. Est-ce qu'on peut supprimer Est-ce qu'on peut supprimer ici parce qu'il y a des trucs qui vont... Non, ça supprime, supprimer ça. Et tout, ils verront ça. Non, mais nous l'affiche. Tu peux mettre.
Jamais, Dr. Eschenberger, on voit que vos pages, hein, on voit rien d'autre. Au cas où.
Okay, do you hear me?
Yes, we do.
Okay, so first, thank you, Marina. Thank you, Ingrid, for the invitation. Thank you, Jean-Louis, to share a moment to present our specialty. So good afternoon, everyone. It's not anymore the morning here in Switzerland. And this is not a picture of our hospitals, but a part most famous in the world of our country. So first, let me introduce myself. I'm Alain-Stephane Eschenberger. I'm a staff anesthesiologist and consultant at the University Hospitals of Geneva, and of course in the anesthesiology department. I'm involved and in charge of a non-operating room anesthesia, what we will talk about later, and also emergency room and sometimes neuro anesthesia too. So first, what is anesthesia? Because Jean-Louis told you we are doing some procedure under anesthesia. Anesthesia is a reversible state of loss of consciousness. It's also amnesia, it's analgesia, we won't forget that, immobility, and it's induced by medication. It's modern anesthesia start about 175 years, a bit more when you see what did the pioneers of anesthesia. First, John Priestley, who was a chemist and who made the first synthesis of laughing gas we call azote peroxide, so NO2. We have also Michael Faraday, was a pioneer a bit later, and he discovered the anesthetic power of ether. The first act, the first procedure published and successful of anesthesia should have been made by a dentist at Hartford. It's in not far from Boston, and it should have been an experimentation with the analgesic properties of NO2 for tooth extraction. Unfortunately, it was a failure. And it was not much later. It's so 175 years ago, the 16th of October of 1846, a dentist called William Green Morton, who published the first successful trial of combined use of ether and NO2. And it was made in Boston, in a theater, in a Bullfinch Amphitheater in the University of Boston. If you want to go once in Boston, you can visit it. It's still on place. Again, some more history of anesthesia. So we talked about the 19th century. And a thing that is very interesting is that our specialty, the MD in anesthesia, didn't exist at that time. So these were mainly surgeons that contributed to the progresses of anesthesia. And the first tracheal intubation was documented in Scotland by a surgeon called William Massewan in 1978. And the first monitoring, it was sphygmomanometer, so blood pressure was done very early in the 20th century by a neurosurgeon. Talking about our medication, one of the first hypnosedatives was thiopental, discovered and produced in 1932. Then ketamine, we'll talk a bit later, in 1962. And one of the most famous and most used every day in the world, propofol, in 1977. So you see, more of the drugs used in our specialty are not very old. Opiates were used, commonly used since, as we know them in the second part of 20th century, even if we know that long time ago, at the beginning of the 12th or the 11th century, the properties of the opiates were already known, so about 1,000 years ago. And we'll talk later about total intravenous anesthesia that we use to have the more stable anesthesia during a procedure. So why do we do anesthesia? Because we could do a procedure without anesthesia. The thing is that if you are doing a procedure or an operation without anesthesia, you will go through a lot of problems. First, endocrine and stress reaction. You will enhance immunosuppression. The catabolism will increase. You will have also sleep disorder and disorientation for the old people. And one of the biggest problem is that you will increase morbidity and mortality. You will also increase tachycardia, oxygen consumption, and you will promote also hypercoagulability, what is a very big problem now. So what shall we do as an anesthesiologist before an anesthesia? And it's very important to do it. First, we have to make an assessment, a preoperative assessment. And the goal of it is to assess every system, the respiratory, cardiovascular, endocrine, and screen medical-surgical antecedents, see if there are some allergies, drug use or drug abuse, and have a look at how are the airways, the upper airways of the patient. The goal of that is first to have a reduction of perioperative risk of complication and to define a strategy, an anesthetic strategy. The goal of course, the third goal of our preoperative assessment is also to inform the patient and sometimes also his family. After this, because consultation, this pre-op assessment, we have for every patient, we have to do a score. This score is ASA classification. So the ASA is the American Society of Anesthesiologists, and it's used all over the world now. And you see that this score is going to ASA class 1 to ASA class 6. And of course, ASA class 1 is a healthy patient, and ASA class 6 is a very morbid patient that is in declared brain dead. But we mostly have to take care about patients between ASA 1 and ASA 5, fortunately. So we have seen our patient in the assessment. We will define a strategy, and then we have to go under the procedure or the operating act. And so we have, it's not very complicated, but we have 3 main families of medication that we use for anesthesia. As you can see, we have hypnosedative. These medications are made for loss of consciousness and also for amnesia. We have the opiates that we use for central analgesia that are very important. And also for most of our procedure, we need to have some muscle relaxant that will promote immobility, very helpful for the surgeon, or for example, for my colleague, for Professor Frossard, so the patient won't move during the procedure. I'm not going to do through an anatomical course, but why are acting? What is happening when you have pain? You see that when you have pain, there are a few parts of the brain that are activated in the brainstem and also the amygdala, the thalamus, and there will be a pathway, an ascending pathway, and then a descending pathway to answer to this to the pain provoked by the procedure. So that's just a picture of a slide with all the opiates actually that we used in our practice. Part of carfentanil that we use only for only for animals. With that kind of medication, with our opiates, here it's written opioids, we will act on this pathway promoting pain, and you see that we will block this pathway at some points, like at the thalamus, for example, and in the brainstem. This is a longitudinal section of the brain. Sorry, I didn't precise it. So first we have the opiates for pain. We have also, as I told you before, for loss of consciousness and for amnesia, we have intravenous anesthetics like propofol, that is the most famous, but we have also since decades volatile anesthetics that we used mainly, of course, by breathing, and that they have the same actions. And again, if you look again at a longitudinal section of the brain, it will act on several parts of the brain to make this loss of consciousness and this amnesia. It's different place than where are acting opioids and pain, but it's again mainly in the brain. And I will stop for this very, very short anatomical course and just have one slide on the muscle relaxant, just to tell you that these muscle relaxants to promote immobility are not acting on the brain, but are acting on peripheral muscles they will block the conduction, so they will block contraction of muscles directly between the nerve and the muscle in question. So that's a picture of one of our anesthetic machine. You see, it's very common all over the world. It's always the same. We have this machine, the machine with a breathe system, with our volatile anesthetics, and of course, during all the procedure or the operation, we will record all the vital signs during the procedure. We have also very special monitoring. This is not the monitoring we use every day, but for other purpose like cardiovascular surgery or neuroanesthesia. And I listed some of this monitoring that probably some perhaps you know, like pulmonary artery lines called the Swan-Ganz catheter. We can also do transesophageal echocardiography. That is very helpful monitoring for patients that have cardiac problems. We can also monitor the intracranial pressure, renal function monitoring, coagulation monitoring with a thromboelastograph, of course, gasometry with acid-base monitoring. We can also monitoring depth of anesthesia with a device called BIS. But we don't do it. We do all that kind of devices. We use it if necessary. So that's a picture like traditional operating room as you most know it, and you see it on movies, for example. That's another picture, but it's not on the traditional operating room. It's what we have. We are practicing sometimes with Professor Frossard. It's anesthesia in non-operating room, and it's for example in gastroenterology, in pneumology, in radiology, neurointerventional radiology. And I can tell you that it's more and more, it's taking importance, and we have more patients every year. Of course, that's typically in Swiss. We can also do. You see, the patients here is well covered, but we do also. We are involved, the anesthesiologists in Switzerland, in the airborne patients with the Swiss medical ambulance rescue called REGA. This is also another kind of anesthesia, but we don't practice so much as we practice other kind of anesthesia. And we will soon be at the end, but let's talk about some, before ending this this presentation, let's talk about risk in anesthesia, because it's a very common question we have of our patients. They are not afraid of the procedure, they are not afraid of the operation, they are afraid of anesthesia. They often ask us, am I going to awake? And what we can talk to them, and yes, you are going to wake up after the anesthesia. As you can see, there are several surveys, like in the survey in Netherlands, so 3 Austrian survey, one French survey. And the conclusion of all these surveys is that the morbidity or the mortality due only to anesthesia is about one patient in about 150,000 on 180,000 patients. So if you look, we have about we have about 30,000 anesthesiologic acts every year in Geneva. So you have to, every 6 years, we can say we have one death that we can attribute only to anesthesia. And most of these deaths are not preventable, but I'm losing my word now, these are deaths that are expectable on very unhealthy patients, very ill patients. So when we have this one dead person on 150 patients, it's most of the time expectable. And so what is the future anesthesia? The future anesthesia, and we started that on most of our hospitals, is adjuncts of anesthesia, like, for example, for hypnosis that we are developing since 30 years in Geneva. Of course, relaxation for the patients with a lot of comorbidities. We have some protocols to do some prehabilitation before their operation or before their procedure. And most of it, we are more and more doing ambulatory anesthesia. And it's especially very important for all the procedure we have with Professor Frossard. Most of our patients can enter the hospital in the morning, and we can discharge them usually at the end of the afternoon after the procedure under anesthesia. That is very important. So I would take a message, and I will thank all of course, Professor Frossard. So you could see it's a preparatory assessment. It's always very important to see the patients before to define the strategy. The multimodal aspect of anesthesia. So we are using 3 main families, but every year we can add some medications that will help patients to be more comfortable. Very important also, it's teamwork. It has been now about 13 years I've been working with Professor Frossard, and what is important is to talk and to define how will be our procedure, how long will it take, what will be the main pitfall situation in our procedure. One thing I didn't talk about is we are, since about 15 years, we are doing a kind of checklist, so safety, to be sure that it's the same the patients that we want to, it's the good patients, not another one. It's not a patient with the same name, but another identity. So we are doing checklists like in the civil aviation. And the 5th message, the future, but I told you about just before. And so I thank you for your attention. Don't forget that it's a teamwork, and we have to rely on each other, so the procedure is going well from the beginning at the end. Thank you, everyone.
Thank you very much, Professor Frossard, and thank you very much, Dr. Eschenberger. This was a very interesting presentation. Is there any question at all? I don't know if Marina, you have question on your side?
No, thank you. But it was really very interesting. Thank you very much, Professor Frossard. Thank you, Dr. Eschenberger.
Yeah, it was very interesting. I've learned lots.
Exactly.
I have learned lots of things. I can rely on them for the anesthesia now.
Definitely, yes. Thank you very much for your attention.
Yeah.
Thanks to you.
Do you have some questions? Maybe.
Is there any other question? It looks like everyone understood everything, so that's perfect.
We were very clear, I'm sure.
I'm sure it was more than clear.
Yeah, anyway, the link with the recording of this webinar we can find off our website. And I think we will send you the copy of this webinar as well.
Well, if there is no other question, as up to now, we will continue to present you the best doctors in Geneva. And we can already inform you that our next webinar will be held on Thursday, the 25th of November. And it will be dedicated to gynecology. We don't have the theme right now, but as usual, you will receive the information on time. If there is no question, well, on behalf of Swiss Medical Gate, we would like to thank you very much for your participation, all of you, including the medical team with Professor Frossard and Dr. Eschenberger and Marina, of course.
Thank you very much.
We hope to see you back for our next webinar, as I said before, on the 25th of November. Thank you very much and have all a very nice afternoon. Thank you. Bye.
Thank you. Bye.
Bye.
Bye. Professeur Frossard, je sais que vous avez coupé votre micro, on vous contacte plus tard.